So ultimately, this will impact things in this way. This gene that I'll be talking about is called 3-hydroxybeta steroid dehydrogenase. It is the master switch, yeah, it's easy to say that. It is the master switch for converting precursors to testosterone and dihydrotestosterone into dihydrotestosterone, and it sits way up in the pathway. And what we have discovered is that some men are born with a single point mutation in that gene that makes their tumors much more efficient at making dihydrotestosterone, which is what drives prostate cancer. And we have great clinical correlation that shows that men who have that mutation, who are born with that mutation, actually progress to metastatic castrate resistance faster and die at a higher rate than patients who don't have that mutation. And so the specific clinical scenario that is evolving, if we can prove this right in a prospective fashion, is that men who have the normal variant of this gene can probably be treated by androgen deprivation alone, things like Lupron or other LHRH antagonists or agonists. But men who have the mutation are actually exquisitely sensitive to the androgens that come from the adrenal gland rather from the testis. And those are patients who probably should get combined androgen blockade, not only an LHRH agonist or antagonist, but an agent that targets the androgen receptor directly. And so it has very specific and useful information attached to it that we think is going to make men who have this mutation live longer. And then that's men who are born with the mutation. It's also probably true that some established tumors that don't start with that mutation acquire that mutation as they evolve. That's a somatic mutation. And so we may be able to genotype an individual's metastatic disease as well and decide which medications they're going to respond to or put them on different medication entirely.